Welcome everyone to the first of 4 webinars in our series, Head and Shoulders, Knees and Toes, Neurological Presentations and Serious Mimics, hosted by the Physician Learning Program, the Office of Lifelong Learning, and the Multidisciplinary ALS Clinic. My name is Melanie Hetherington, and I'm an education specialist with the Office of Lifelong Learning and the Physician Learning Program. Our mission here at the Physician Learning Program is to create actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. We are dedicated to moving evidence into practice by fostering a culture and environment where everyone works together to tackle our most pressing problems. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Just before we begin, I'd like to go over a few housekeeping items. Please use the chat feature if you have a question about technical difficulties or any of our programs and services. If you have questions for the speakers, please use the Q&A feature of the webinar. Please review what has already been asked and upvote those questions you would like answered. There may be an opportunity for those of you who would like to voice your questions aloud to do so, but we won't be able to guarantee that we can get to all of the questions today. We'll do our very best, though, to try. We will be using Mentimeter for this presentation, so if you'd like to join in and participate in the interactive discussions, you can scan the QR code on the screen here. Westerly will also be putting the link in the chat, so you can click on that to be directed to the Mentimeter slides. A recording of the webinar and the Pearls for Practice document will be sent via email to all of those who have registered for this session, and it'll be sent after that 4th session has been completed. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. Participants can also claim certified Main Pro Plus credits by completing a personal development activity using the MyL3 plan, and I'll be talking about this a little bit later in the presentation. For more information on that plan, the MyL3 plan, you can scan the QR code on the screen. And now I would like to introduce to you our 2 speakers for today. So we're very pleased to have Dr. Wendy Johnston and Dr. Mark Ng here for our session, Foot Drop, Is It Always Sciatica? So Dr. Wendy Johnston is a neurologist and professor of medicine in the Division of Neurology at the University of Alberta. She's also the former medical director of the K. Edmonton ALS Clinic. Her research focuses on neuromuscular conditions, including ALS, and she also does EMG. Dr. Mark Ng is a full-time practitioner in physiatry with his own practice, including EMG. He also has training in neuromuscular conditions and provides physiatry support to the ALS Multidisciplinary Clinic. So thank you both so much for joining us today, and I am going to turn it over to you.
Thank you, Mel, and thanks to Westerly, who is behind the scenes doing our slides and keeping us on track. So thank you for attending today. I hope that you find our session useful. It is supposed to be interactive, and I wanted to let you know that this is the first time I've used Mentimeter, and this platform is new to us. It also is a little bit of an unusual format for this kind of webinar to have 2 speakers, but I think it's a way for us to interact. Certainly working with Mark in preparation for this was a tremendous learning curve for me as well. So as we proceed, we're going to be doing case-based studies of a common presentation and then an uncommon presentation. And a lot of what we're going to be focusing on today is really what you're thinking as you're seeing one of your patients and as you move forward to trying to understand their condition. And what are the challenges in navigating our system? And that's where the feedback will be very helpful as we move forward. As Mel said, this is the first of many, first of 4 presentations, and I hope those of you who attend today will be coming in for the next 3 as well. I think in the chat we already see that we have, I'm in the sidebar, and Wes, you have a big block with just your W, and then the slide is small. So I'm not sure what the technical reason is, but the slide is not coming up full screen. There we go. All right, so the first Mentimeter task is to throw yourself in and tell me where you're coming from. And I know we have 48 participants coming on, and I'm hoping that more of you in the time frame that we're going to give you to declare where you're coming from. Someone's already accused me of bias, and Mark has correctly pointed out it's not bias if it's evidence-based. I appreciate that support, Mark. Go Oilers. All right, how much time do we have left in this first slide? Is we're getting some participation. I was really excited that we would be using the Mentimeter platform because of the interactive potential. When it's a larger participant number, it's harder to come in individually. So that's why I'm hoping these will be ways for you to participate and tell us what you're thinking. So we're seeing, we see people south of Red Deer, more from the Edmonton region, and 1 north rural. Oh, and someone's coming in from New Brunswick. Does that mean that you're just really sad that Montreal is out of the playoffs? We've got 7 seconds to go. More participation, please. All right. So we see a definite Edmonton region representation and some south of Red Deer. And then I guess our New Brunswick person is technically south of Red Deer. I hope that's where you threw your hat in the ring. Next slide. So our goals today, again, the hockey theme, is to talk somewhat about the key clinical features for differential diagnosis of common, uncommon, and rare causes of foot drop, and to talk a little bit about foot drop itself. I also felt that we needed to share some information about EMG, that not all practitioners really know what goes on with an EMG, and that would help you and your patients understand what the role of EMG is and how to access it. And then we also feel that in order for you to get the best consult, that we may need to provide you some guidance on what will help your consultant triage your patient to the priority you feel is appropriate. Next slide. So just to start off, again, a participation theme. So we've said what else besides sciatica causes foot drop? So when that came up, what were some of the thoughts that you had? Could you just type in a diagnosis? You can type in more than one. And I would just invite you to put in as many as you can. So when we think about the diagnosis of foot drop, one of the things that I, as a neurologist, always think about is whether the foot drop is flaccid or spastic. And so, good point. CP, MS, so these are upper motor neuron, and you're honing in right on one of my points. If you just go and Google foot drop, you'll see a bias towards peripheral causes. So anything from the nerve root on down. Whereas patients can present with difficulty with dorsiflexion, which is foot drop, for other causes, way up into the central nervous system. So someone has correctly brought up injury. So maybe it isn't even neurological. And as a neurologist, I tend to forget that. I tend to think about it's always got to be something that that is wrong with the nerves or muscle. Someone's throwing in myotonic dystrophy type 1. That's a very informed opinion, because many people think of muscle disorders as being mainly proximal, but myotonic dystrophy is one of the hereditary muscle disorders that can present with peripheral weakness, typically hands and at the ankle. So that would be tended to be more of a symmetrical foot drop. So we see disc prolapse coming up, injury, stroke, very good point. Congenital, so more in the CP realm. Have we run out of time? And I see a lot of you feel fairly shy about using our interactive, or you haven't quite got into the practice of using the QR codes and using Mentimeter. So I invite you to keep trying to download this onto your smartphone. And if you don't have a smartphone, well, hooray for you for your boundaries. But this is the way that you could potentially interact. So if our time is up, we're on to case 1, and I'll turn this over to Dr. Ng.
Thanks, Wendy. So our first case here, relatively short one, and I'm hoping that this is familiar to most people with regards to initial presentation to some of your clinics. So let's start off with a 46-year-old guy here. He's not a construction worker by trade, but he's one of these guys who likes to tinker around his own home. So one weekend he decided, okay, well, it's springtime, summertime, the weather's good. I'm going to go start building my deck. And then, of course, you know, with the lack of disorganization he had, with the lack of experience, he tended to bend over and reach over to get up one of the boards. And he just put himself in kind of a weird position, did a little twist in his back and said, oh man, what's going on here? Well, twinged him back, didn't think too much about it. He was left with a bit of back pain, but continued going and going on his way. And throughout that night, that back pain was getting a little bit worse. But he thought, I'll probably just sleep it off. I'm 46 now. I'm no spring chicken no more. I'm not 20 years old. I'll probably sleep it off, and tomorrow morning I'll be much better. And he wakes up next morning and he said, man, this back pain even got worse from yesterday. And now it's actually shooting down into the right leg. Man, it's going through my butt and going through the thigh and into my leg and finally down into my foot. And when I tried to go and have the first bowel movement of the day, as I'm pushing down and trying to get some of that stuff out, man, that shooting pain is going straight down. And it's like, okay, well, maybe this is just from the original injury that I had yesterday. So he starts walking around, see if he can loosen up, limber up a little bit, see if he can go back to working on that deck. And then he started realizing, geez, what's going on here? My foot's starting to slap around like a fish out of water. And so he continues going, thinking that things would get better. This is not a guy who's, sits on his bum all day. He's going out into his home doing stuff, and everything he's doing is kind of painful. And so he hangs out until about 2 weeks later, comes to your office. And when you examine him, you've realized now that he's got some ankle dorsiflexion weakness, and he's noticed that himself at this point. He's got some sensory loss in the same distribution as pain running down in from his buttock into the thigh and leg and finally into his foot. And you're trying to palpate around to see if he's got specific tender points, because he said things are so painful, but really not specific tenderness that you've identified on your exam. So let's go to the next slide. And I think we've got a little bit of a survey going on for the next slide. So we're going to take a look, put our neurology hat on and see exactly where the localization might be in the neuro axis here. So we've got brain, spinal cord, anterior horn cells, the nerve root, in this case L5, lumbosacral plexus, and finally down in the peripheral nerve and the peroneal nerve. So we see here where a lot of people are voting into L5. Looks like a lot of experience with the same sort of problem, common problem coming into people's practice. Probably even similar presentation. So I guess that's the end of voting. And so far only 6 votes. Of course, we didn't have very much time to do so, but of course, time is always fleeting and limited. And so it looks like most people are looking at that L5 being the most likely localization. So now that we're thinking L5, most most people are, okay, let's concentrate our examination into some few things and maybe get rid of some of the red flags that we have to be aware of. So let's take a little bit more of a detailed history. Let's continue on with, okay, so we can continue asking any bowel and bladder changes, none. Speech and swallow changes, none. Looks like there's nothing going on in the upper limbs, motor sensory dysfunction, nothing going on in terms of past medical surgical history. Pretty healthy guy to begin with. This is a type of person who comes by probably once a year. He's in once every year or 2 years to do an annual checkup, and nothing really is wrong with him. Healthy guy. And then examining further, you do the reflexes, which is pretty normal in all 4 limbs. The plantar responses are all downgoing as well. And really, the only thing you can find on motor sensory exam is really just in the right lower limb, and all the other limbs are spared. And moving on further to the next slide. So really, I mean, I guess before we're saying what was the likely localization, and we provided some additional information as to what the most likely diagnosis is at this point. And so right now we've got a minute on the clock, and take a look at your responses.
This is really to see if more people have been able to get on Mentimeter, because there was some chat about not being able to access it. There's a link that's been put in the chat if you're interested in throwing in your opinion.
And I suspect some people will also be using their phones to access Zoom as well. So a bit awkward to switch back and forth between Mentimeter and checking out the presentation.
I think that everyone had honed right in on the most likely diagnosis. I feel like there's a big red arrow pointing at the spine when you have radicular pain. But it's also useful to just tick off all the pertinent negatives to ensure that you're not being misled by someone who may have 2 diagnoses. So I think that the additional information just helps you cement your approach.
So it looks like we're dealing with experienced practitioners here in the community. Let's continue on. So when we're and I put this all out so that way we can kind of lay out our individual thought processes and taking a look at red flag symptoms and signs, and taking a look at our examination findings and trying to rule in and rule out different localizations. So here I've kind of broke this down, and obviously everybody is pinpointed that this is a nerve root problem, so I've not included that here. But for example, looking at brain or spinal cord, central nervous system causes, really there's no upper motor neuron signs and symptoms. There's no upper limb symptoms, which is of course key. Bulbar symptoms such as speech and swallow difficulty, bowel and bladder change, which would be more common and more obvious in the spinal cord injured population. And really, if we're taking a look at his symptoms specifically and his signs, is really exclusive to that right lower limb, kind of ruling out a more diffuse process or something that's more centrally caused, such as the brain and spinal cord. And then moving down to the anterior horn cell, of course, we consider most anterior horn cell diseases, of course, we're sparing all the sensory features, and this individual has pain and sensory features right off the bat. And if we're talking about something that it affects the anterior horn cell, most of those things would affect you in a progressive state. And in this individual, it happened right away. He was working on his deck and immediately felt that, and it was the next day, had significant issues. Down in the plexus region, again, we're talking about this gentleman having mostly distal motor weakness rather than more diffuse weakness. And in the case of lumbosacral plexus, and then we would expect more things proximal and distal as well. And finally, towards the perineal nerve, we have to look at the fact that the sensory changes were also in the buttocks and in the thigh, which is proximal to the distribution of perineal nerve. And then next slide, please. So this is interesting in terms of, so what would one do for this person that you've just seen? You're suspecting an L5 radiculopathy, and now your plan for this individual.
And more than one answer could be inputted.
Yes. So we're seeing more of a spread this time, which is good. Gives us a lot more to discuss. Looks like most people are going the physiotherapy route, and then individuals are maybe starting neuropathic pain medications, and selection of people going for plain X-ray, MRI, but nobody has gone for an EMG. Okay, so that's perfect.
Very interesting spread of responses.
This is very
Thinking is
interesting.
2 EMGers. That's quite fascinating. And so, did you want to address your thoughts on the different choices?
Yeah, so I think the important thing to note is that there is no perfect answer for this. A lot of it depends on patient preference, obviously. Some of it depends on the degree of symptoms, and really the progression of the course of the person's clinical profile. So some individual come in and they'll like, okay, I don't really like to do medications, for example. I only want to do things that, such as physiotherapy. Some people say that it's been a week or 2 weeks now, and things are maybe a little bit better than they were previously. So I'd like to hold off 2 weeks before we investigate. And some people will say, we got to do something right away. So I think the only thing here that I'd like to bring some attention to is the plain X-ray. So many of the guidelines coming out for, at least for physiatry, I would suspect that neurology is the same sort of way, is that presentations that align well with a radiculopathy, an X-ray doesn't really bring all that much utility, and really is more used for things like if you're suspecting that this is for example, a fracture, or if you're considering that this is maybe a screening tool for an invasive bone lesion or a malignant bone lesion or something like this.
So, for example, if this is a patient who's a 56-year-old woman who had breast cancer last year,
absolutely,
that would influence your decision to do a plain X-ray because you'd be concerned about a bone met.
Yes, those are good points. So a lot of it, of course, has to do with clinical picture and looking what things are best suited, but especially for this individual who's previously very healthy, then most likely the X-ray would not provide any additional utility. An MRI could be reasonable. For example, if we're thinking about doing certain injections for someone suffering in pain, and then we're going to talk a little bit more about EMG today, so I'll kind of hold off on that. And physiotherapy is definitely not a wrong answer because for many individuals, they just maintain mobility, motor function, and eventually things get better, especially with things like, especially we're talking about lumbosacral things. Sometimes the traction can be helpful for that if done with enough force and done properly. So again, a lot of nuance into this particular answer. So thank you for weighing in, everybody. Anything else to add for you?
We didn't give you the choice of bed rest, right, Mark?
Fair enough. Yeah.
That's one of the reasons physio's a good option is we're not promoting bed rest for this presentation. It used to be in the old days, right? You'd put people to bed and get them recover, but recovery now actually depends on being mobilized.
Absolutely. Okay. And let's move forward here. So, I guess we'll put this slide in just to give you a sense of, so I'm a physiatrist by trade, and of course, Wendy is a neurologist by trade. So looking at the differences between referring from physiatrists and neurologists, can be a little bit difficult to make that decision on when you're kind of on the battlefield. Now, of course, there's nuance to be had with this. For example, myself, I'm neuromuscular trained and I did neuromuscular fellowship. So my experience is a little bit different from other physiatrists as well. But of course, when we're talking about physiatrists in general, we all have a certain know-how and certain practice patterns. So when we're talking about pain, and especially we're talking about things like spinal cord, those are type of things that a physiatrist can deal with well. Radiculopathies, a lot of experience with that as well, given that a lot of it ends up being pain related. But we're also particularly good at keying things between it is more of a musculoskeletal cause versus something more like a neurological cause. And giving a differential diagnosis, and some of you have indicated in the past as well with our Mentimeter, with regards to, hey, this could be musculoskeletal pains. It could be pains that are not related to the neural axis at all. I know we only indicated at neural axis type selections, but certainly we have other reasons why someone has pain. So a physiatrist may be reasonable for that as well. But anything along the neural axis, I think a physiatrist would be relatively comfortable with, or after seeing that person, because it is a consultation. And Wendy will talk a little bit about the utility of EMG and what's involved in an EMG and the consultative process that's involved in an EMG, where we can also refer forward towards our other colleagues who work closely with us, such as our neurology colleagues. Is there anything else you want to add with this, Wendy?
So one of the differentiations that I see between us is I feel like physiatrists are really doers. And so when you talk about someone who has the pain, differentiating from MSK, I feel physiatrists are better at the MSK differential diagnosis. In the setting of someone who's limping, who's got radicular pain, who it's not clear if they're just guarding or they actually have weakness, that additional MSK input is very valuable. And I don't feel as a neurologist I do as good a job. When someone has clear-cut weakness, when they have the slapping foot, I think you could toss a coin between a neurologist and a physiatrist in terms of diagnostic strategies. But again, in terms of doing therapeutic interventions, I think that physiatry kind of cuts to the chase. And aside from the medical management of pain, which I think we both do, there's a lot more orientation to how could you be intervening to get the rehab process started. I did have a question, though. In your slide, you put forward flexion with twist, not just standing, suggests radiculopathy. Are you talking about their gait and how they're holding their body when...
This is a discussion we had, Wendy, regarding radiculopathy. So a lot of the radiculopathies are caused by forward flexion with a twist.
It's the cause, yeah.
Yeah, and that's based on, I don't want to take too much time doing this, but it's based on the structure of the annulus, and the way the fibers of the annulus are structured, and the way the facet joints are structured to restrain twisting movements, except for when someone is forward flexing, then they can twist more readily and therefore cause annular ruptures and therefore causing disc herniations. So that's a very classic story about how someone develops a radiculopathy.
From a disc herniation. So
that's correct,
maybe it's distinct from someone who's got spinal stenosis or other cause of injury. Great, yeah, let's carry on. We're not doing too bad for time. So in conclusion, you had some follow-up.
So as I said, a lot of the specific treatments and managements of this individual is really nuanced and really depending on the presentation and progression of this person's symptoms. So when you end up offering this guy is like, hey, listen, we can do some neuropathic pain medications, or we can send you for an MRI. And then he said, well, he's not in too much pain, but maybe give me some medication just to kind of tie me over if it's necessary. And so he said, well, later, actually, wait, I'm writing something different, I'm saying something different. So he said, I'm in a lot of pain, give me some medications. That's fair enough. And while I'm getting this medications, he's also being sent for an MRI and an EMG. And then because the reason why we sent for an MRI is because he's in so much pain, the additional managements may be necessary. So he may need an injection, and eventually he may need surgery, and therefore MRI would be indicated in that. And the EMG may have some utility. So while he's waiting for his EMG, he did get his MRI two months later, which does demonstrate multiple levels of disc herniations, and at these levels, at the L4-5 and the L5-S1 level. Now, based on this examination, we can be quite clear that this is an L5 radiculopathy. However, because dermatomes are not perfect, so sometimes you might have a concordant, L4 plus a little bit L5. So should we also deal with the L4 all at the same time? So this is where EMG can be helpful in clarifying whether or not this person has an L4 and an L5 or just an L5, because as we know with MRI, MRI is very sensitive in looking at radiculopathies, but it's not as specific as something like an EMG to help clarify which particular one should be the target. So in this case, the EMG was able to clarify, okay, it's more likely that the L5 is the one that's involved and looks like the L4 is not really involved. So we can probably get away with just doing that single injection in the L5 and kind of leaving that L4 for now. And I think that's basically it.
And MRI is really excellent at the anatomic localization. It's able to show you just what the anatomy is, and but anatomy is not always destiny. So which is the symptomatic route? So clinically you suspect an L5, the EMG confirms it's L5. If an injection doesn't work, then the surgeon may go in and say, I can do a microdiscectomy. This is going to be a very neat, very focused, very low intervention, well tolerated. So it's the additional localization. And even in a fairly clear-cut case, when a patient's been sent directly to a surgeon, I've had the surgeon turn around and request that myself or one of my colleagues do an EMG just to confirm that this is the process and that there's actually enough going on, that there's denervation, that the nerve root is affected enough that further intervention may be required. We'll come back to the Q&A at the end because there's been a couple of excellent questions that were put in the Q&A for you, Mark.
Will do. So
we're going to go ahead with case 2. So this is the one that isn't as straightforward. So in this case, and I should emphasize that Mark and I made these cases up from our experience. This is not a particular patient. It's just a conglomerate, if you want. So this is a 52-year-old right-handed male accountant. He's noted a gradual onset of functional change. He's saying he's walking more slowly. It's taking longer to complete a golf game. His swing is okay, but he's tripped and almost fallen a couple of times if he's not paying attention. He feels like he's almost dragging his right foot. He started to lift his right leg consciously, particularly when he's going from one surface to another. He's had chronic low back pain without radicular symptoms for many years, which he manages conservatively, and he reports no sensory symptoms, no bowel or bladder complaints. He's sexually active, he has no erectile dysfunction. His family history is negative for neurologic disease. So in your office, in my office, and I think that probably the way I do my notation is a bit different from someone who's in primary care. But I do the cranial nerve exam, the upper extremities in a screening fashion, and nothing is abnormal there. But in the lower extremities, his symptoms correlate quite well with what I find. He has increased tone in the legs. And by increased tone, I mean I can move them and they move en bloc. They don't have a floppiness that a relaxed patient should be able to obtain. And compared to Mark's patient, distally in the foot isn't floppy, it's actually moving. All the muscles are kind of moving together. However, interestingly, there's atrophy of the tibialis anterior muscle in the right leg. And he noted, and some muscle twitching, which he hadn't really noticed, was apparent in the proximal and distal muscles. He has no weakness on the left, and the weakness on the right is not as dramatic as you might think from his history. So 4 out of 5, he's able to demonstrate good resistance, especially if you give him enough time to really pull his ankle up and don't surprise him by just jumping on it. He has increased reflexes in his arms and legs, but they're quite markedly increased in the right leg. And his plantar response is upgoing on the right. That is, he has a Babinski response, and it's downgoing on the left. So what is the localization of this problem? And I think there's only one answer. You don't get to have multiple. And I hope people are comfortable with doing the Mentimeter, because I'm really interested in your response. So 3 people are opting for brain, 2 for spinal cord, 3, okay, 4. Jump in there, please. Yeah, people are committing themselves more for brain, more for more for spinal cord, so a bit of a battle going on here, but pretty much everyone so far is opting for central. Does the atrophy mean anything? This is a history of maybe 3 months total duration. Do you think that that is consistent with central? Is there a reason for that? That is the question. So we'll carry on. So everyone opted for central. I'm going to take a moment and use this cartoon to review motor findings. So the emphasis very much of today's presentation and those going forward will be on motor function. It's not to say sensory is not important, pain's not important, not at all, but we're focusing on motor today. So in order for us to move a muscle, we need to generate the motor program in the brain, and that's the upper motor neuron, and it comes from the cerebral cortex. It then travels down into the medulla, and it crosses to the other side, goes through the cervical spinal cord, the lateral cortical spinal tract of the thoracic spinal cord, and exits in the lumbosacral spinal cord. So of course this is for our patient with foot drop, whether it's an L5 radiculopathy, when it's a peripheral impression on the exiting nerve root. But there is the crossing, so that central findings are, of course, crossed. So if someone has increased reflexes on the right, then we suspect the left brain. But in the spinal cord, the crossing over, the decussation of the pyramids has already occurred. So when you have a spinal lesion on the left, then you would have increased reflexes on the left. So for this gentleman, if the increased reflexes are on the right, it could either be the left brain, the right spinal cord at one of these levels. What it can't be, what increased reflexes can't be due to, is lumbosacral disease, because the conus ends at the upper upper segments, and so if you have increased reflexes, the sole explanation cannot be found in the lumbosacral spine or with a lumbosacral MRI. So just to review, upper motor neuron signs, very little wasting of muscle. The tone is increased, or it might be spastic, so fully increased tone is spastic. You have brisk reflexes, and primitive reflexes, in this case the Babinski sign. In lower motor neuron signs, characteristically of wasting, decreased tone, reduced or absent reflexes, and fasciculations. Now we'll do the next slide. So what are you going to do now? I think you get a full minute to tell me what you'd like to do. And I believe you can do, I think we can do more than one answer here. So now we see some interest in EMG. Thank you, Mark and I thank you. MRI for some, and physiotherapy and reassure, again, not wrong. Many people are opting to refer to a specialist, and because we will have time at the end, I'll be very interested to get some feedback, whether it's in this session or subsequently, as to what it was about this scenario that prompted the higher interest in referring on to a specialist. And at this time, not a lot of interest in medication for cramps. Maybe that's more patient driven. Maybe the cramps is just a by the way kind of symptom rather than something to be addressed pharmacologically. All right, so a lot of interest in doing further investigation and referral to a specialist. Next slide. So what are some of the red flags that would prompt referral or to move this into a more urgent process? So continued progression is a red flag, emergence of bowel or bladder complaints, progression to a different region, developing more distant symptoms, so speech or swallowing changes, and any red flag should prompt more urgent referral for specialty assessment, including the planned imaging or EMG. Next slide. So 2 months later, the patient returns. Now you had, in fact, booked for a 3-month, but he has requested to be seen sooner because of because of falls. His cramps and stiffness have worsened, and he's had his MRI because he didn't want to wait, and he went ahead and obtained one privately. The MRI obtained was of the lumbosacral spine. On your examination, in addition to the findings that you noted previously, he now has some weakness in the left leg, and the reflexes are increased as well. At this time, the EMG appointment is still pending. That's real life, isn't it? So what would you do next? Can you rank these by importance? I'm really flogging the Mentimeter. I'm using it in all its different parameters. So you have 1 minute to rank what you might do next. So you know that he has a normal MRI of the lumbosacral spine. I put that in because so many times as a specialist, a subspecialist reviewing cases, I see that the initial request for MRI was lumbosacral spine. And that is kind of logical, because if it's the legs, you think lumbosacral spine. And yet the increased reflexes would turn you away from that as an explanation for the entire presentation. In a sense, it's not wrong to do, because Occam's razor being what it is, although you want one diagnosis or one cause for everything, Hickham's dictum dictates that patients can have as many problems as they like. And so there's nothing to say that there's a lumbosacral stenosis that could be complicating the presentation. So we do learn something from this MRI, and the fact that it's unremarkable is very helpful. So in this case, your votes are in, and I don't see the numbers, but I see that MRI of the brain has come right up there. Resending the EMG request to mark it up to urgent. MRI of the spinal cord is vying there, and there's a rearguard action to do some routine testing. And as I tell the residents and students, it is never wrong to do a B12 and TSH in neurology. So when in doubt, B12 can be surprisingly, even if it was tested within the last 2 years, it can still have dropped and be contributing to the presentation, notably the increased reflexes. The progression would suggest not, and the lack of sensory would suggest not, but again, it's not wrong to do these additional blood works. Next slide, please. So when do you refer to a neurologist for foot drop? So in this case, he had insidious onset. He can't link it to a particular event. It doesn't have sensory change, and no pain. So there's nothing really there's no smoking gun to say an injury's occurred, there's a disc, there's something that is causing this progression. In his case, he has findings of mixed upper and lower motor neuron science with the atrophy of the tibialis anterior and the increased reflexes. And with the second visit, while he's being under investigation, he's had progression. Fortunately, he has not had progression to other regions, but that would be an additional cause for heightened concern. Next slide. So, in conclusion, this patient was seen 3 weeks later on the referring doctor's request for an expedited EMG. As we'll go into a little bit, EMG, the actual EMG, is where the money's at in this case. But he had nerve conduction studies which showed no evidence of a neuropathy. The electromyography of the right leg showed acute and chronic denervation in multiple muscles, not confined to one nerve root or peripheral nerve territory. And the accompanying consult confirms their clinical examination of upper and lower motor neuron findings and suggests referral to a specialty clinic with a likely diagnosis of amyotrophic lateral sclerosis. Next slide. So just to take a step back, in this case, many of you opted to say you'd prioritize a consult to a specialist. And so why would you prioritize that rather than do your own investigations? Well, I'm hypothesizing that you're really looking for a diagnosis, and I think that's what we all are looking for when we bring a consultant in. Direction for further management is a big part of the consultation, and you might actually want the management to be in the hands of the specialist. One of the questions you have to ask yourself, and this may be more pertinent to our first case rather than our second, is it worthwhile seeking a consult? Well, if a diagnosis is still up in the air and you're not really sure what to do, then from a physician point of view, it's very important to get that input, especially as primary care, where you're kind of left holding the bag to say, I need to be continuing to follow my patient. But in the first case, When you have someone who has something that might have a benign or reversible natural history without more than supportive interventions, it's a consultation with the patient to say, I'm going to refer you in case surgery might be indicated. I could be referring you because I would like to know if there's further interventions. And if the patient's like, nope, don't want that, then it's entirely reasonable to hold on and follow with the patient before seeking a consultation. And this involves sharing concerns about a potential diagnosis with the patient. I'm being told to keep an eye on the clock. Okay, next slide. So EMG, what do you get? So in this illustration, the EMG is being done of the hand, but the principle is the same. We use electrical stimuli recording from muscles for motor studies, and we record from skin sensors for sensory studies. That gives us the nerve conduction studies. The EMG, needle EMG, as illustrated in the other picture, you have your grounds there, and you have, this is probably a monopolar needle because there's two grounds, and we're getting recording directly from the muscle without electrical stimulation. So EMG is what we casually refer to as the test, but it's really nerve conduction studies and electromyography. And you need to know, if you don't know already, that only labs accredited by CPSA with a physician supervisor who has CPSA approved training as a lab director may undertake testing. So unlike in other jurisdictions where, for example, physiotherapists can do nerve conductions in EMG, only physicians with specific training in specifically approved labs can undertake this. And unlike EEG, the patient is seen and examined by a specialist physician. Sometimes in some labs, the physician does the nerve conduction studies as well as the EMG. In larger labs like the one I practice in, we have a registered technologist who may do the nerve testing. The electromyography is always done by the physician. Typically, with a EMG study, clinical consultation and a clinical diagnosis is rendered as well as the interpretation of the data. Next slide. So who does them? Well, Dr. Ing and I, so neurology and physiatry, we receive training within our residency program, and we can go on to do subspecialty training in neuromuscular disease or in electrophysiology subsequent to our training. But it is integral to our training, and we have to, in order to be accredited by CPSA, we have to pass our exams in our specialty, and we have to demonstrate subspecialty training as well, which includes, for the CSCN, which is the Canadian accreditation, includes completion of over 400 supervised cases within the last 5 years. So it's a very rigorously controlled subspecialty, and both neurologists and physiatrists do it. I say the consultative process where you get the opinion is probably influenced by the background of neurology or physiatry. So the question is, does your patient need a separate referral to neurology or physiatry or just an EMG referral? And this has come up multiple times. Now that I'm on Connect Care and I can dialogue with our referring clinicians at times, many don't seem to be aware that when you refer for an EMG, you're actually seeing in our clinic a neurologist. And particularly if you've indicated a particular diagnosis, for example, myasthenia gravis or ALS, that the triage process will direct the patient towards someone who has a subspecialty interest in that particular condition. Next slide. So when you refer to EMG, what happens? Well, we do triage, and so both Mark and myself triage individually. We review what's the information sent in to us. Sometimes we can make a decision right then on the acuity, so the timing. I say, you'll need to see this patient within a month. Or sometimes additional information is requested, largely to know if there's a greater acuity or if prior testing has been done. Sometimes you triage and direct to another provider. It turns out the request for an EMG is better managed by a general neurology consult first. Or sometimes referrals declined because the referring physician has indicated that, for example, this pain is the only referring question. And so sometimes that might be appropriately addressed to another situation. Sometimes the urgency of the referral is such that an urgent neurology assessment should precede the EMG, since EMG labs can get a little backed up. Next slide. So out of curiosity, I wanted to know, in your practice, for routine requests for EMG, how long are you waiting? Wow, that's quite a difference. Let's get more people.
How do I interpret this chart?
Um,
I'm
so,
confused.
so 12 is 12 months.
Yeah,
Um,
but like the blobs.
I think the blobs are like individual people. So again, um,
Okay, I gotcha.
we're not getting a lot of input so far, but we're seeing quite a spread. And so what I'm seeing is I had to give a correct answer. And within our lab, our goal is to have a routine, get appointments within 3 months. Now, I have to say, when I see patients and I see that I triaged it to 3 months and I'm seeing them at 5 months, that to me is an internal sign that we need to improve. But I'm concerned to see that 12 months is not unusual in our responders. Next slide.
Which is interesting, Wendy, because my current wait list is 2 months.
Yeah. So
So
that's
because
that's
it's individual practitioners, right? So it just depends who you send it to. So
exactly.
depending on which lab you send it to, so some labs, of course, have very long lists, and other
Yeah.
labs have barely a list at all.
Yeah.
And but nobody knows that because we don't have a centralized process. Unlike
Yeah.
something like Calgary, which is more centralized, but in
Yeah.
Edmonton, we're so fragmented that we have someone like myself who was at one point I was seeing people less than a month,
Yeah.
and then now it's around 2 months. And then there's labs where they're waiting 9 months or 6 months.
Yeah. Yeah. And so that's to me a quality improvement goal that I set for the region. I'd love to have central triage, and there's problems with central triage. And in our subsequent presentation in the weeks ahead, talking about central versus personalized referral, it's a real, which one is better? If central triage gets your patients in faster, that's better. If it means that you don't get the discerning opinions from a respected colleague, then referring to a specific colleague is better. So it's an ongoing debate. Next slide, please. So this is just a list, and this can come out in pearls. You may have heard that the quality of your consult depends on the quality of the referral. So if you do minimal information, then you might just get a very factual, nope, it's not an R5, it's not an L5 radiculopathy back. So if you send a patient in with a list of symptoms, a concern that this is a progressive disorder, it will be likely triaged to a higher priority and get a more discerning consultation. Next slide. So what to do while you're waiting? So manage symptoms, reassess, and the Canadian pattern of just being waiting and being a good patient needs to be mitigated by the reminder to call in to get reassessed, and then you can in turn as a physician up the ante and try and get that patient advocated for. If expedited referral is not forthcoming from the person you refer to, then you might consider other pathways such as rapid or consult MD. Next. And so the other thing that came up, and I think, again, running out of time, sometimes you send a patient in with a question and you get an answer that isn't helpful. Like, is this an L5 radiculopathy? And the answer is no. And it's like, they still have a foot drop. Could you at least give me a differential? Can you give me some guidance? So what do you do then? So a second opinion, an EMG from another specialty, revisiting the consultative request, or call someone. Again, if a patient's progressing, I would say call someone. You're not getting the answers you need. Next slide. So a couple of resources for virtual consultation, and there was in the revolving slides, ConnectMD is a consultative virtual consultation that will get to a telephone response within 48 hours. And there are 2 neurologists, and I just talked with one of the neurologists who is an EMGer about taking calls, and so I'd encourage reaching out. And then I do get, when I've been on call, rapid calls from physicians saying, I don't know what to do, or I'm concerned. So these are 2 resources. Next slide. So we're at the end of the presentation, and I apologize for taking too long, probably because I interjected too much, but we have a number of chats. So I'm just going to read of them. So there is a recording. The slides will be distributed. Yeah, that is why we as GPs will consult a specialist, as you'll get preference when referring a patient. I hate to say it, but that's true. I've been referred someone for, please see, I think they have ALS, and I see them like, oh, it's not ALS, but I think they've got a significant cervical myelopathy. And I've been able to expedite the MRI in a way a community-based family doctor just can't. So getting the consultant in as another advocate is a really concrete strategy. And then Karen had a question. Did you want to speak up now? Or did Karen have to leave? Because she put her hand up earlier. One of the questions that was asked about was the prognosis in L5 radiculopathies. Will they get better on their own? Mark?
Oh, you want me to take that? Okay, sure. So the answer, I guess it depends on the degree in which we're talking about. Typically, you do have some improvement, but because the tibialis anterior is pretty far away from the back where renervation has to happen, so a lot of times you do have some longer standing deficits moving forward. But at the very least, for most people, their pain symptoms do improve. So it depends on the degree, though. For many people, they do improve enough where they don't notice it nearly as much. And then for some, they really don't improve a heck of a lot, unfortunately.
Mm-hmm. And so, in short answer is I tend to refer to surgery if it's spinal stenosis. And if it's a clear-cut disc, I think the prognosis is better for conservative. And so there is a bit of the MRI is helpful in that respect. And then the natural history. If they're coming in and seeing you and saying, yeah, I'm improving, then I think there's a tendency to see how much can be done because there's risk with surgery. There's risk with injection. Mel has some final words.
We really appreciate your feedback, and we really do want to make sure that we're meeting your needs. So if you are able to please complete our evaluation form, that really helps us plan our events for future programs that we put on. So I've just put that in the link as a thank you for completing our evaluation. We do have a raffle for a $10 Starbucks gift card. So we would really, really appreciate any feedback that you can give us on the presentation. I also wanted to mention that we are hosting a PLP Summit. It will be it's on advancing practice through the power of partnership, and it'll be held here in Edmonton on June 11th. And our key speaker for that event is Dr. Victor Montori from the Mayo Clinic. So we're really looking forward to seeing you there as well. And I'm going to put a link to the registration in the chat as well. And I'll turn it back over to you just to finish up some last questions there, Wendy.
Yeah, there were a lot of questions that came in on the end, and Mel can tell me if there's a way for me to provide answers afterwards. If people have a minute to stay on. I don't think you can elaborate on the injections for pain management and so on. That's a separate talk. Urgency timeframe for workup, for foot drop. Honestly, I would say within weeks. And when you fill in the form, there's extra space where you have to talk about urgency. When I bugged the radiologist, they say just put the time frame and why. And so someone who's got significant weakness, you can say, I want this within 6 weeks. And then you can have your MOA call in and say, I asked for this to be within 6 weeks because they're weak. And that's important. And then I don't really understand the question. Could there be a potential of a centralized process for EMG? So there are ways to evaluate the CNS electrophysiologically and magnetic stimulation.
No, Wendy, she's not talking about that. I think she's talking about centralized process for referrals.
Yeah, I'm working on it, Rebecca. I'm working on it. That's my dream. To get gradually get more of the labs to agree to have a central referral to even out. The first step has been our lab. We now have a central triage because we used to be individual physicians as well. So gradually, I'm hoping to spread that out. People who have waiting lists feel loved, and those who have a long waiting list feel secure. And so having to deal with consultant sense of security in the referral base is one of the, I would say, challenges of working towards a more centralized referral process. So it's a
So
good
Wendy, I
question.
also left my email in the chat just in case individuals had questions that they wanted to ask away from this particular forum.
Okay.
And mostly because I got to go back to clinic. So
Yeah. All right.
I gotta head out.
Just before we leave, I just want to thank you both, Dr. Ng and Dr. Johnston, for such a wonderful presentation. It was really fantastic, and I really appreciate you using the Mentimeter as well, and hope that was interactive and fun for people to participate in as well.
Maybe next week, not so many. And foot drop from perineoplastic, not unilateral. So anonymous attendee, I have not seen a unilateral perineoplastic process presenting with that. Neoplastic, but not perineoplastic. Okay. Thanks, everyone. I hope to see you all next week.
All right. Thank you. You guys take care.